When a young investment banker learned that several of his good friends were participating in a local 5K race, he decided he would try to quickly get in shape and join the fun. Although he didn't exercise regularly, the young man figured if he really pushed, he could be ready for the race in time. But on the very first day he began training, the man quickly developed pain in the lower part of his buttocks and the back of his thigh. The pain was especially intense when he bent over, like to tie his shoes, and left him with a limp that convinced him there was no way he could participate in that 5K. Those of you who run probably already know what happened to this guy, but let's learn about the muscles and bones of the thigh to bring everyone up to speed. And yes, that's a running pun. As we begin, remember that the thigh has 3 compartments of muscles that surround the femur: an anterior, medial, and posterior compartment. In the last lesson, we looked at the proximal aspect of the femur, including the femoral head, femoral neck, greater and lesser trochanters, as well as the intertrochanteric line anteriorly and intertrochanteric crest posteriorly. Continuing on with our study of the femur, the anterior shaft of the bone is smooth, but posteriorly, the femoral shaft bears a long ridge called the linea aspera. It's a major muscle attachment site for one or more muscles in each of the 3 compartments of the thigh. The linea aspera begins as the union of 2 other landmarks on the posterior proximal femur: the pectineal line medially and the gluteal tuberosity laterally, which you'll recall was part of the insertion for the gluteus maximus. The pectineal line and gluteal tuberosity come together like the arms of the letter Y to form the linea aspera that passes down the posterior femur. Where the linea aspera terminates, it diverges into the medial and lateral supracondylar ridges. In between them is a smooth spot known as the popliteal surface of the femur. The area posterior to the knee is known as the popliteal region. Just distal to the popliteal surface are a pair of smooth, rounded prominences on the femur, called the medial and lateral femoral condyles. Between them is a fairly deep depression known as the intercondylar fossa, while superior to each femoral condyle are prominences called medial and lateral epicondyles, as we saw on the humerus near the elbow. The medial epicondyle is topped by the adductor tubercle, though that can be quite small in some people. Following the femoral condyles around to their anterior surfaces, we find they merge in a smooth, flat area called the patellar surface. This is where the patella or kneecap articulates with the femur, whether the knee is extended or flexed. The patella is a triangular bone with its flat base directed superiorly and its apex pointed inferiorly. Its posterior surface has a pair of smooth facets, a smaller one for the medial condyle of the femur and a larger one for the lateral femoral condyle. Now here's a fun trick when studying osteology. When you put a patella face up on a table with the apex pointing away from you, it always falls to the same side that the patella came from in the body. It leans to the larger lateral facet. In other words, if it leans to the left, it's a left patella. If it falls to the right, it's from the right lower limb. Perhaps I didn't say it earlier, but as a forensic anthropologist, you really need to know your rights from your lefts, whether for teaching or for laying remains out on a gurney in the morgue. Before leaving our discussion of the relevant bony anatomy, let's take a quick look at a few landmarks on the proximal tibia and fibula to better understand some of the upcoming muscle attachments. The tibia has a medial and lateral condyle on the relatively flat area that's sometimes called the tibial plateau. That's at the proximal end of the tibia. So when talking about the articulations at the knee, you need to be specific as to the femoral condyles or the tibial condyles that meet them. On the anterior aspect of the proximal tibia is a bump called the tibial tuberosity, which is easily felt on your own shin. The head of the fibula can also be felt laterally behind your knee, especially if you're sitting down and your knee is flexed. These landmarks will relate to the knee joint, as we'll see in our next lesson. However, at the knee, the femur only articulates with the patella and the tibia. The fibula does not have a bony articulation with the femur. The fibula attaches to a facet on the lateral aspect of the proximal tibia. Now let's return to the fascia of the thigh. As we learned in the prior lesson, the fascia lata encases the muscles of the thigh and has a vertically oriented thickening, the iliotibial tract or IT band, in its lateral aspect. People often have a misconception of the IT band, since anatomy models and images often highlight the iliotibial tract by showing it as a separate structure. But it is part and parcel of the fascia lata of the thigh. It's simply a much thicker region that adds to the strength and stability of the thigh and the knee, especially when the opposite foot is raised. Remember that gluteus maximus has part of its insertion on this iliotibial tract, but another muscle on the anterolateral aspect of the hip, the tensor of the fascia lata, also known as the tensor fasciae latae, is also attached to the iliotibial tract. At the knee, the iliotibial tract attaches to the lateral condyle of the tibia in an area that gets the eponym Gerdy's tubercle. A painful overuse condition known as IT band syndrome can affect distance runners and cyclists in that location. The fascia lata is also bound to other thickened sheets of connective tissue that dive down to the linea aspera on the posterior femur, separating and forming the three compartments of the thigh. As in the upper limb, these fascial planes not only compartmentalize, they also provide intervals in which larger nerves and blood vessels travel to either pass through the thigh or to give off branches that supply the muscles. And with that introduction, let's talk about the muscles in each of the three compartments. The anterior compartment contains the four muscles of the quadriceps femoris group, as well as four other muscles. But I suppose that really depends to some degree on which reference you consult. I teach the 8-muscle scheme in the anterior thigh group, but some consider the tensor muscle of the fascia lata with the gluteal region. As we move into this muscle specifics, let's remind ourselves of the anterior compartment generalizations. Remember that most of these muscles are supplied by the femoral nerve, which is composed of lumbar plexus ventral rami L2, L3, and L4. And in terms of function, any of these muscles that cross the anterior hip will flex the hip, while those that cross the anterior knee will extend the knee, among other functions. Let's start with the most proximal anterior compartment muscle. Psoas major, if you recall, is the muscle posterior to and around which the lumbar plexus forms and distributes in the posterior abdominal wall. Psoas major originates from the 12th thoracic vertebra and the 5 lumbar vertebrae and ends up in a dual insertion on the lesser trochanter of the femur. I say dual insertion because a second muscle, the iliacus, takes origin from the iliac fossa of the hip bone, blends with the psoas major, and together they insert on the lesser trochanter. The two muscles are literally indistinguishable at their insertion. For this reason, many references refer to these collectively as iliopsoas. Because psoas major originates on the lumbar spine, it can help flex the trunk at the low back, whereas iliacus cannot. But both cross the anterior aspect of the hip joint, so together they flex the hip, as when raising your lower limb to step up to the next stair, or to bring the swinging lower limb forward when walking or running. In terms of innervation, iliacus is supplied by the femoral nerve itself, while psoas major is supplied by small segmental branches of the ventral rami off the lumbar plexus due to its proximity near the midline of the body. What about psoas minor? Well, only some people have it. One estimate is that around 40% of people have a psoas minor. But when present, psoas minor appears as a small version of psoas major sitting on the major's anterior surface. It typically originates from T12 and L1 only and inserts on the anterior pelvic bone near where the ilium and pubis meet. It doesn't insert with the iliopsoas. It isn't very remarkable, sorry psoas minor, but that's especially true given students are often looking more at the lumbar plexus formation and its branching in that area. What's more, though they're considered muscles of the anterior thigh, psoas major and iliacus are deep and really more located in the abdomen than in the lower limb. They're often called our deep hip flexors. Once within the anterior thigh, the most superficial and therefore most obvious muscle is the sartorius. In my opinion, it's one of the more interesting muscles in the lower limb, and not only because it's the longest muscle in the body. By the way, you might not realize that the cells within a muscle can be nearly as long as the entire muscle itself. Some of the cells within sartorius are the longest muscle cells in the body, at nearly a foot in length. Sartorius originates from the anterior superior iliac spine and then takes an oblique course to attach to the medial aspect of the proximal tibia. So it crosses both the hip joint and the knee joint. Its attachment to the medial tibia is in a spot known as the pes anserine, from the Latin for the goose's foot. And while it really doesn't look like the foot of a goose, this triple insertion where three tendons converge has been likened to the three toes of a goose. Sartorius is supplied by the femoral nerve, and though its action is rather hard to describe in words, it's a very familiar series of movements. Sartorius is the muscle that you use when you cross your legs to put your lateral leg on top of your opposite knee. In words, what's happening during that motion is that you're flexing, abducting, and laterally rotating at the hip joint, while flexing and slightly medially rotating your knee joint. The name sartorius comes from the Latin for tailor, since in the long ago past, tailors would sit cross-legged with their fabric in their lap while they worked. Another muscle that, in a not-so-obvious sense, could be said to cross both the hip and the knee is the tensor of the fascia lata mentioned previously. In a cadaver, it appears like a pocket or packet of muscle within the anterior and superior aspect of the iliotibial tract. The muscle belly originates from the lateral edge of the anterior superior iliac spine and a pronounced region on the lateral ilium known as the iliac tubercle. It inserts on the iliotibial tract or IT band, which does cross the knee, but the muscle belly really only acts on the hip joint and to tighten the iliotibial tract, thereby supporting the hip, thigh, and lateral knee. Because it is lateral to the hip joint, the tensor of the fascia lata can assist in hip abduction, and because it's anteriorly placed, it can assist in hip flexion, as well as some medial rotation of the hip. The innervation of the tensor of the fascia lata is the superior gluteal nerve, which really breaks the compartment innervation rules of the thigh, and is why some references consider this muscle to be a member of the gluteal group rather than the anterior thigh. If you recall, the superior gluteal nerve enters the gluteal region above piriformis, supplies gluteus medius and minimus, and then continues around the lateral aspect of the hip to reach the tensor of the fascia lata. The last four muscles in the anterior thigh constitute the quadriceps femoris group: rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius. Though they all have different origins, all four of these muscles converge on a single tendon that crosses the anterior aspect of the knee joint. It's in this tendon of the quadriceps femoris group that the patella forms. Then the tendon, now better called a ligament, continues distally to the knee joint to attach to the tibial tuberosity. As an anatomist, I say better called because many people refer to the quadriceps attachment to the tibia as the patellar tendon. However, tendons connect muscle to bone, while ligaments connect bone to bone. So the quadriceps tendon connects the four quad muscles to the patella, then the continuing portion attaches the patella to the tibial tuberosity. In other words, connects bone to bone, so is anatomically referred to as the patellar ligament. Though it's generally a familiar group of anterior thigh muscles, many people don't realize that the rectus femoris also crosses the hip joint, and it's the only one of the quads that does. Rectus femoris originates on the anterior inferior iliac spine and partly on the rim of the acetabulum, crosses the anterior hip joint, and then inserts by the patellar ligament onto the tibial tuberosity, crossing the anterior knee joint. It is used when thigh flexion and knee extension are needed together, like when kicking a ball. The other three members of the quadriceps group all originate from the femur itself, and since they don't cross the hip, can only act in knee extension. Vastus lateralis originates along the intertrochanteric line, the greater trochanter's inferior border, the gluteal tuberosity, and all along the lateral aspect of the linea aspera. So, although it's a member of the anterior compartment of the thigh, the origin of vastus lateralis begins posteriorly on the femur. It passes deep to the iliotibial tract and joins the other three quadriceps femoris muscles to insert on the tibial tuberosity. It is the largest muscle in the body and can be seen and felt all along the lateral thigh. The vastus medialis originates off the intertrochanteric line and medial aspect of the linea aspera, but the bulge of its muscle appears much closer to the knee, where it joins the quadriceps tendon. The final member of the quads, the vastus intermedius, can't be seen at all from the surface because it is deep to rectus femoris. Vastus intermedius takes origin all along the anterior and lateral proximal two-thirds of the femur, including as far posteriorly as the linea aspera. And then it joins the other three members of the quadriceps femoris group to cross the anterior knee and attach to the tibial tuberosity. All four muscles of the quadriceps group are innervated by the femoral nerve. And in terms of exercise, many of you may know that squats, with or without weights, as well as leg presses and leg extensions on a weight machine, can all help strengthen the quadriceps femoris group, among other muscles. Now let's move on to the six muscles of the medial compartment of the thigh. They are the obturator externus, pectineus, the gracilis, and the three members of the adductor group. Only one of the medial thigh muscles crosses the knee joint, but all cross the hip joint. And since most of these adduct the hip, some refer to the medial compartment as the adductor compartment. As we learned previously, the obturator nerve dominates the supply of muscles of the medial compartment of the thigh. But as with the anterior thigh, there are exceptions. Obturator externus originates on the anterior surface of the obturator foramen, then passes posteriorly between the pelvis and the neck of the femur, and inserts just inferior to the attachment of the inferior gemellus muscle. Remember the series of deep lateral rotators in the gluteal region? Piriformis, superior gemellus, obturator internus, inferior gemellus, and quadratus femoris? While it's not easily seen at the posterior aspect of the hip joint, the obturator externus also attaches among that group, just between the insertion of inferior gemellus and quadratus femoris. So not only do obturator externus and obturator internus flank either side of the obturator foramen on the pelvis, both also pass posterior to the hip joint to insert along the deep aspect of the intertrochanteric crest. Obturator externus then also laterally rotates the thigh, like the other members in that sequence. However, it's supplied by the obturator nerve off the lumbar plexus, while those other lateral rotators are supplied by nerves of the sacral plexus. Next, let's look at the pectineus muscle. It originates on the superior ramus of the pubis and attaches to the pectineal line on the posterior-medial femur. Because of its anterior origin on the pelvis and insertion on the medial femur, it flexes and adducts the thigh at the hip joint. In terms of its innervation, I like to tell my students that pectineus is peculiar because it may be supplied by the obturator nerve, by the femoral nerve, or may have branches from both. Keep in mind, though, that both the femoral and obturator nerves are composed of the L2, L3, and L4 ventral rami off the lumbar plexus. So the differences in innervation are likely of little consequence. The most medially placed muscle of the medial compartment is gracilis. Gracile means slender. It's a long, narrow muscle that originates on the inferior ramus of the pubis, runs along the length of the medial thigh, and attaches to the pes anserine region near the medial condyle of the tibia. Like most other medial compartment muscles, gracilis adducts the hip and is supplied by the obturator nerve. But unlike any other muscle in the medial compartment, gracilis crosses the knee. And due to the position of its insertion, gracilis can also act to aid flexion of the knee. The three muscles of the adductor group are named for their relative sizes: adductor brevis, adductor longus, and adductor magnus. Magnus means great in Latin, named for its great size. Typical of longus and brevis pairs, the adductor longus is more superficial. It sits just medial to pectineus and takes origin off the anterior aspect of the body of the pubic bone. It inserts on the middle third of the linea aspera. Adductor brevis is deep to the longus, and it originates off the inferior pubic ramus and inserts on the proximal third of the linea aspera. Now, both of them adduct the thigh, but can also assist in flexion of the hip due to their more anterior origin and posterior insertion. Both adductor longus and adductor brevis are supplied by the obturator nerve. I should also add here that sartorius, adductor longus, and the inguinal ligament border a region known as the femoral triangle, which is of clinical relevance due to the femoral artery, vein, and nerve within it. The femoral artery can be used to draw arterial blood gases, as well as for insertion of an intravenous line or catheter for certain cardiac procedures. Now, the last adductor of that group is adductor magnus. It's another muscle I find particularly interesting. It is said to have two parts based on its different origins, insertions, actions, and even innervations. The adductor portion originates on the ischiopubic ramus and inserts on the linea aspera. Like its longus and brevis buddies, the adductor part of adductor magnus is also supplied by the obturator nerve and adducts and flexes the thigh. But the adductor magnus also has what's called its hamstring portion, which takes origin off the ischial tuberosity and inserts on the adductor tubercle, projecting off the medial epicondyle of the femur. Like the hamstrings of the posterior thigh, the hamstring portion of the adductor magnus extends the thigh and is supplied by the sciatic nerve. Now, I suppose it's anyone's guess why early anatomists called psoas major and iliacus two different muscles, despite the single insertion that allows the combined name iliopsoas, while at the same time adductor magnus also has two very distinct origins, but really just one name. This reinforces something I haven't reminded us of in a while, that all this naming, whether of muscles, nerves, or anything else, is a human construct. The body doesn't care what we call its parts, and the whys and the wherefores of naming are simply part of anatomical history. One other feature related to adductor magnus and to how things are named is the adductor hiatus, Now that's a natural opening within adductor magnus near the insertion of its hamstring portion. The femoral artery and vein pass through this gap to travel from the anterior thigh to the popliteal region behind the knee. That's the point where the femoral vessels are renamed as popliteal vessels. The large femoral artery and vein don't run across the anterior knee, where we might kneel and compress them, but rather pass posterior to it by going through the hiatus in adductor magnus. The remaining muscle compartment is the posterior thigh. It contains the three hamstrings, semitendinosus, semimembranosus, and the biceps femoris. Each of the hamstrings take origin, all or in part, off the ischial tuberosity, but they differ in their insertions. As its name implies, biceps femoris is a two-headed muscle. Its long head comes off the ischial tuberosity, but the short head originates from the linea aspera and lateral supracondylar ridge on the posterior femur. The two heads converge and insert in common on the head of the fibula and lateral condyle of the tibia. So only the long head of the biceps femoris extends the hip, whereas both heads cross the posterior knee to help flex it. The remaining two hamstrings, semitendinosus and semimembranosus, both take origin off the ischial tuberosity, the common hamstring origin, and together they travel to the medial aspect of the proximal tibia. Now, students frequently confuse the hamstrings, so one trick is to look at the popliteal region where the three muscles diverge. The two muscles that sound alike, semimembranosus and semitendinosus, attach medially, but biceps femoris has a different sounding name. And I tell my students to allow the F in femoris to remind them of the fibula, since biceps femoris heads laterally toward the fibula. But how do you sort out semitendinosus and semimembranosus, they ask? Well, when you see the two muscles in comparison, the thing that really sets them apart is that semitendinosus has a long cord-like tendon that is superficial to the semimembranosus, while semimembranosus has a sheer membrane-like tendon, both at its origin and its insertion, though that's hard to tell from images. Also, the M's in semimembranosus help us remember it's the more medial of the two. Where all three hamstrings cross the posterior hip, they extend it. All also cross the posterior knee, so act together to flex the knee. Biceps femoris is also said to assist with slight lateral rotation at the knee, while the semimembranosus and semitendinosus assist with slight medial rotation of the knee. Now, keep in mind, though, the knee doesn't perform any significant rotation unless it's badly injured. This refers to slight rotary movements, such as when we lock and unlock the knee joint. And while all the hamstrings are supplied by the sciatic nerve, we can be even more specific here. Both the semimembranosus and semitendinosus are supplied by the tibial portion of the sciatic nerve. The long head of the biceps femoris is also supplied by the tibial part of the sciatic nerve, but its short head is the only muscle in the body said to be supplied by the common fibular portion of the sciatic nerve, before it branches into the superficial and deep fibular nerves. At the point where it supplies the hamstrings, the sciatic nerve still appears as a single entity. But remember, even in the gluteal region, the sciatic nerve is already committed to its two main branches. I should also mention that semitendinosus is the third and final member of the pes anserine insertion group, which interestingly includes one member from each compartment. Semitendinosus from the posterior thigh, gracilis from the medial compartment, and sartorius anteriorly. All three muscles come together like a tripod and attach at the proximal medial tibia. And because the insertions are slightly posterior to the hinge joint of the knee, all aid in knee flexion. Just deep to the goose's foot attachments, the pes anserine bursa can swell and cause painful bursitis at the medial knee. Causes range from obesity and flat feet to wear and tear, whether from work or exercise. Speaking of exercise, remember our young banker who decided to quickly up his game to participate in a 5K with friends? The rapid onset of pain in his buttocks and posterior thigh was a big clue to the group of muscles he injured. Many of you may have recognized this as a pulled hamstring injury. When he bent over at the waist, the pain got worse since that position stretches the hamstrings, which were already aggravated. But he probably should have done those stretches before he started his rigorous training. I'm sure those of you who run recognize that this guy began training too fast and perhaps didn't warm up before or stretch after his activity. Fortunately, mild hamstring injuries benefit from RICE therapy. That's rest, ice, compression, and elevation. But perhaps this guy could have avoided the entire injury by first strengthening his hammies, as many athletes say. He could have done that by using a weight machine for lying, standing, or seated leg curls. Severe hamstring tears apparently actually make a popping sound when they occur and may require surgery to reattach muscles literally torn from their origin on the ischial tuberosity. And on that cringeworthy note, we'll conclude our study of the thigh.